Hi everyone, thank you for joining us and welcome to today's webinar on joint surgery on your radar, what you need to know. So my name is Jess, I am Health Promotion Manager at Arthritis Queensland and New South Wales, and I'm very excited today to have 4 guests with us to present and share a little bit about their own experiences as well. So before starting, in the spirit of reconciliation, Arthritis Queensland and New South Wales acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community, and we pay our respect to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander people today. So I'll start off with firstly introducing our first speaker, Ilana, who will explain a little bit more about how today's webinar and panel discussion will run, and we'll introduce our other guest speakers as well. So Professor Ilana Ackerman is the Deputy Director of the Musculoskeletal Health Unit in the School of Public Health and Preventive Medicine at Monash University. She's a musculoskeletal epidemiologist and an experienced orthopaedic physiotherapist. Her research program aims to understand the impacts of osteoarthritis and outcomes from joint replacement surgery. Ilana is an osteoarthritis expert for the Global Burden of Disease Study, and she's been involved in the development of models of care and clinical standards for osteoarthritis. So I will hand over to you, Ilana.
Thank you, Jess. Thank you so much for the kind introduction. Good afternoon, everybody, and welcome. I'm so pleased that you've joined us here today for today's webinar. I'm just going to share my slides and hopefully you'll be able to see them okay. Jess, can I just confirm that you can see those okay? Fantastic.
Yes.
Okay, so I have the great pleasure of kicking off today's webinar, but we really do have a fantastic panel of speakers for you today after I speak. So I'm going to give you first an introduction to arthritis and joint replacement, but just for an overview of today's webinar. So I know today's focus is on joint replacement, but I really felt I couldn't speak about joint replacement without taking a step back and just giving you some brief information about arthritis first. And then after my presentation, I'm going to introduce and hand over to Associate Professor Sam Adie, who's an orthopaedic surgeon who's here with us today, and he'll give you a presentation from his surgeon's perspective. And then I'll introduce you to our consumer experts, Jen and Robert, who are here with us today, and we'll have a hopefully really good panel discussion about their own experiences before and after joint replacement surgery, and then we'll open it up and have plenty of time for questions and audience discussion after that. So just to start with, I wanted to have today's introduction as a really sort of general overview and some background information for you, practical information. And in putting this together, I've tried to think about all the kind of common questions that come up from patients who are considering having joint replacement surgery or perhaps getting ready to have their joint replacement, and wanted to share some different online resources that you can freely access if you'd like to go off and find some more information. There's a lot written about arthritis and joint replacement on lots of different websites. So I think it's really important to go to the ones that are evidence-based for any information that you might be looking for. So first one I can point you to is the Arthritis Australia website, and it's got some really good background information about what is arthritis, the different types, the areas of the body that are affected, and different management options. This information is also available through the state-based arthritis organisation, so Arthritis New South Wales as well. But just by way of background, in very general terms, arthritis is a condition that affects the joints. It most commonly affects the cartilage and the bone in the joints, but it can also affect the muscles and the ligaments and other structures. And it's really an umbrella term for any of these conditions. So there's actually over 100 probably different types of arthritis. Stopped. The most common symptoms that people will be familiar with is pain, probably the most common symptom that people present with, joint stiffness, swelling around the joint, and restricted movement of the joint as well. Talking about main types of arthritis, the 2 main types would be osteoarthritis and then inflammatory arthritis. And inflammatory arthritis, again, is another collection of lots of different types of arthritis. But as I said, osteoarthritis is the most common type, and it's estimated to affect over 2 million Australians currently, and that's increasing over time as the population ages. Osteoarthritis commonly affects the knees, the hips, the shoulders, and the spine, so the neck and the back as well. Osteoarthritis is more common amongst older age groups, and it's also more common among women. I wanted to really highlight that even though osteoarthritis is really common, not everybody progresses to having severe osteoarthritis. So not everyone is going to end up needing a joint replacement, and some people will have milder or moderate osteoarthritis that can be managed through the different non-surgical options. Another website I just wanted to share with you today is the My Joint Pain website, and that's also partly hosted by Arthritis Australia, but there's lots of information there about osteoarthritis and other joint conditions in terms of diagnosis and management plans and different treatment options there too. So what is joint replacement? Well, it's pretty much a surgical procedure where one or both joint surfaces are replaced with an implant, or sometimes you'll see that called a prosthesis. And there are different types of implants or prostheses that can be used for the joint replacement. And there's also different approaches for the surgery, so different ways of getting to the joint. And the surgeon will base that decision around what implant to use or what approach to use based on a few different things. So firstly, the evidence for how good that implant or the approach is. Secondly, based on their own expertise and their experience with doing that type of procedure, but also the patient's own individual circumstances for their arthritis. So what joints are replaced? Well, mainly the knee and hip and shoulder joints, but you can also have other joints replaced. So ankle joint, the elbow, the wrist, and much less commonly little joints of the fingers, but all of those are much less common than the knee, hip, and then the shoulder. You may see the term partial joint or hemi-joint replacement come up, and that's where one compartment of the knee joint might be replaced rather than both main compartments of the knee joint. You can also have a patella or kneecap replacement where the back of the kneecap is resurfaced or a button is used there. And when people talk about a partial hip replacement, that's usually done for the management of a broken hip or fractured hip rather than for osteoarthritis. And then a total joint replacement is where both surfaces of the joint are replaced. So in the case of the hip, the ball and the socket are both replaced. And in the case of the knee, both main compartments of the knee are replaced. And sometimes, or quite commonly now, the kneecap can be resurfaced at the same time. So I wanted to put joint replacement in Australia in context for you. There's lots and lots of joint replacements that have been done in Australia. So our National Registry has collected data on almost 2 million joint replacements done in Australia as at the end of 2022. And as this graph shows, those numbers have been increasing over time. So in dark blue, we have the hip replacement numbers, and then in the lighter blue, we have the knee replacement, and in orange, we have shoulder. So we can see those trends of increasing hip and knee replacement over time. We, of course, have a little quite a marked drop in the COVID years when we had the lockdowns and no elective surgery, especially in Victoria and New South Wales, and then the numbers have been climbing back up since then. A bit hard to see from this scale on the graph, but shoulder replacement has been increasing steadily. We don't have as many years of data for shoulders. I've just shown a few years there, but hip and knees are definitely the most common, but shoulder replacements are actually increasing at a faster rate in Australia than hips and knees. Just wanted to pop this up here because it's important to understand that joint replacement is not the first step in managing osteoarthritis. There's lots of other steps before that in terms of non-surgical options, and it's important that you work through these with your GP and your other healthcare providers. So we based our treatment on the care guidelines and the clinical standards in Australia. And for all people at any stage of managing their arthritis, the most important things are education about their condition and some support to self-manage arthritis. Exercise therapy and maintaining or increasing your physical activity are also highly recommended, and so is weight management. And that might not be just weight loss, but it might also be preventing weight gain. There's also some treatments, and these are intended to be just sort of general advice, and you should most definitely speak to your own health professional about your circumstances, but the sorts of things that are not recommended because there's no evidence to support their use or because they might have harms associated with them are opioids, stem cell therapies, supplements such as glucosamine and chondroitin, platelet-rich plasma injections, and also a knee arthroscopy. Okay. Wanted to touch on today about setting realistic expectations before joint replacement. Hopefully we can touch on this in the panel discussion too, because I think it's really important to go into the idea of surgery with some realistic expectations. So I think the first important point is to really think about what your short-term and your longer-term goals are for having a joint replacement. And that might be in terms of what you hope to gain in terms of pain reduction or improving your function or other specific activities such as work or sport that you want to be returning to. And then it's really important to have that conversation with your surgeon about what is achievable in your own circumstances in terms of the goals that you might have. And thinking in particular about activities such as, returning to tennis or skiing or running or high impact activities that might involve jumping, for example. These are sorts of things that if you want to be doing those kind of activities after joint replacement, that's really a conversation to have with your surgeon about whether that's going to be feasible and achievable and how that might potentially impact the longer term outcome of your joint replacement. I think it's also important to say that not everybody experiences full pain relief after joint replacement. And while many people will experience very large improvements in their pain, I think that's also important to understand that you may not be completely pain-free. And certainly that's the case for many people in the early months after surgery. It's also not uncommon to have, in the case of knee replacement, some knee stiffness that persists for weeks or many months afterwards. And so it's important to have some realistic expectations around that. And after your surgery, even after you've done your rehab, you might still have some restrictions in the amount of movement you have in terms of lifting your shoulder up or in bending your knee. So all important to think about and discuss with your surgeon. So in terms of the education that you should receive before your joint replacement, that can be provided in lots of different ways. Some hospitals, for example, have a pre-admission clinic where you'll go and meet, for example, the physiotherapist and the nurse and possibly the anaesthetist. Other places have a joint school where there might be group sessions that you go to with other people and hear from different health professionals. And some hospitals or individual surgeons or clinics might have leaflets or refer you to online websites where you can access more information. It's a really important opportunity for you to understand what's likely to happen during your time in hospital from just before the surgery through to the time you're going home and when you might be likely to go home. And it's also an important opportunity to help you understand your likely sort of path of recovery once you come home from hospital. It'll help you understand what sorts of things are used for pain management and how the timing of medications might be considered sort of before your therapy session so that you can maximise the rehab that you're going to do. They should also give you information about your home exercise program and a walking program to build up your endurance after your surgery as well. It's an opportunity for the clinicians to understand your home situation. For example, if you've got 2 flights of stairs and your bathroom and your bedroom's only upstairs, that's really important to know. Or if you've got steps going into your house and no rails, or if you've got an unusual bathroom set up, it's important to help us understand that. But importantly, it's a chance for you to ask any questions at that time and for you to seek clarification on anything that you're not sure about or is unclear. In terms of the rehab after the joint replacement, this can be provided in lots of different ways, and that might depend on where you live and your circumstances or whether you're going through the public or private system. But rehab can be done as an inpatient, so in an inpatient hospital kind of setting. It might be done as an outpatient at a hospital, or you might go to a private physiotherapy clinic, or you might have a physio that comes to visit you at home. The types of exercises that you do are fairly routine and standardized, and ideally these will be sort of explained to you before your surgery, but the exact exercises might depend in individual cases depending on any restrictions that the surgeon has requested, if they've done something slightly different or perhaps they've used bone grafting or a slightly different approach, and that might also affect the amount of weight that you're allowed to put through the joint in the early days. Rehab starts really early for people who are on same day or short stay hospital programs, so going home within a couple of days. That rehab can sometimes start within hours of surgery. People might be getting up out of bed with the physio and starting just standing and short walks. But for most people, that will be up and out of bed the next day after surgery. The exercises should be already fairly familiar to you from the education you received before surgery. And the main goals of rehab and physio in particular are really to make sure that you're safe and independent with getting in and out of bed, getting in and out of a chair, walking using your gait aids, whether that's a frame or crutches or something else. We're helping you to regain your range of movement for the joint that you've had replaced and regain the muscle strength around it. So all in all, that you can return home safely and return to the functional activities that you want to be doing. For some people, the rehab might also include some water-based therapy or exercise programs. That will depend again on where you're going, and it will also depend on your wound healing and perhaps whether you've had staples or stitches, etc., for the wound. Okay, I just wanted to finish up with a final slide on what is normal in the early weeks after surgery. And this is something that people commonly worried about. Is what I'm experiencing normal? Am I progressing normally? So I thought it's a good opportunity to sort of provide some information about this. But basically, anything can be considered normal in the early weeks after joint replacement. So first starting point is in terms of pain. Pain is a very unique experience. Everyone will experience pain differently. So it's important to firstly understand that the pain after joint replacement will be different for everybody. All of your health professionals, your doctors in particular, your surgeon will be helping to make sure that you are, as comfortable as possible after your surgery, and certainly comfortable enough for you to be up and walking and doing your exercises. And the pain can vary from day to day and from hour to hour in the day, and it certainly can vary quite considerably over the first 6 weeks to 3 months, but in general terms, the pain will be decreasing over that period. Bruising is something that people are commonly concerned about after surgery. So again, this is very normal. The bruising is as a result of the surgery that's been done, but what I wanted to say, it's also very normal for bruising to move around. So while it might start, for example, around the knee, as people are up and about and spending more time on their feet, it's very normal for that bruising to basically just move down with gravity. So one day you might wake up and see bruises around your feet or your ankle, and people can be worried that they've done something wrong or injured themselves, but it's not the case. It's the bruising that was up around the knee and has made its way down with gravity. So very normal. Bruising is something that can take sometimes weeks to resolve, and it can change colours and move through greens and yellows. So people can be quite worried about that, which is very normal, but it's not an issue. Swelling is also normal, particularly after knee replacement, and it's again a result of the surgery and the inflammation that's going on there, often in a kind of tight space around the knee. What is important though is that if that swelling is accompanied by a new pain or heat or tenderness around the calf muscle, that you do tell your doctor so that they can have a proper look and see if there's any signs of infection or any blood clots. Tightness at the front and or sides of the knee after knee replacement is incredibly common, and again related to that swelling and bruising. Numbness around the wound is again something that people can worry about after their joint replacement. It's very normal and will usually resolve with time, and it's just around the incision and the little nerve endings to the skin there that have been affected by the surgery. Feeling tired is also incredibly normal. It's a very big procedure. Even if you can only see the relatively small wound, there's a lot that's been done to the joint, and there's the anaesthetic and the medications as well. So it's very normal to feel tired. Important to pace your activities, and if people offer to help once you're home, do take them up on that offer. And also do make sure that you have rest times once you go home from hospital, and perhaps try and minimise the visitors that come if you can as well, because the rest is really important. Upset tummy and constipation in those early days is something that's also pretty common, and patients will often tell us that in the gym that their tummy is not feeling right, and that can be related to the medications and not moving around as much. So do tell your doctor about that, because perhaps there's something they can do to assist you with that. And the final thing I wanted to really emphasize, it's really important to not compare yourself to others. I know it's human nature to want to do that, but I see this happens a lot in group class settings, or when people come to the physio gym and you see people walking up and down in the rails, the parallel bars, or people doing different exercises, or people using different gait aids, and it's only natural to compare. But just remember that everybody's different. The people that you see may have had different types of surgery. They may be further along in their recovery pathway than you are, and everybody's circumstances before the joint replacement are very different. So please do try and reduce the temptation to compare yourself to others, because it's your own recovery pathway that's important, and that's the best thing to focus on. So that's all I wanted to say, but I'd next like to introduce Associate Professor Sam Adie, who's with us today. Sam is a highly experienced orthopaedic surgeon, and he's going to now give us some practical insights from his expert surgeon's perspective. So thank you, Sam. I'm going to stop sharing my screen and hand over to you.
Thanks so much, Ilana. So nice to meet you, everyone, and it's a pleasure to be here. I'm going to dive straight into this because I think what I'd like to do today is maybe just spend a few minutes on this presentation, but just focus more on the panel discussion. But I was just, I guess, thrown some questions in preparation for this talk, and I think these are very much questions that I get asked by patients when they come and see me when they want to consider a joint replacement. They're by no means exhaustive and in no particular order, so I'm just going to go dive in and just address them, and then hopefully we'll have a chance to cover some other issues during the panel discussion. So first one is different surgical approaches for hip replacement. So we can access the hip joint using three main approaches now. The posterior approach still is the most commonly done in Australia. It's about 2/3 of all of the approaches that we do. Anterior is getting commoner. It's probably about a quarter to a third of the operations that we do. And then lateral is the least common and probably getting a little bit less common as time goes on. So really the two main ones that you will see these days are posterior or anterior. As you can see from this diagram, and this is sort of like a pretty complicated diagram, but this is a sort of a cross-section of a human body. But the posterior approach here is represented by the blue line. And you can see that part of the posterior approach involves going through a muscle, or rather splitting that muscle sort of in line with the fibers of the muscle. You're not actually detaching that muscle. Whereas with an anterior approach, I guess the beauty of that approach is that you can go between the muscle intervals in order to access the joint. Okay, but you can see by, with all of them, you're doing the same thing. You're accessing the hip joint, regardless of which way you go about it. You're accessing the hip joint in order to perform the surgery. And the other thing to note is that all of them can have some sort of minimally invasive option. Okay, people like to throw these terms around because they sound really, really good and make people feel more comfortable doing the surgery. But whether you do a posterior or an anterior, they all can have sort of minimally invasive options. What I guess you need to know as someone potentially considering this surgery is there's no one clear superior option. Okay, so they both have their pros and cons. And what I've tried to do here is list, I guess, stuff that's a little bit more evidence-based, rather than if anyone's ever gone online and done a quick search of this, you'll find like a plethora. You'll find like reams and reams of, internet pages just advertising, I guess, one approach over the other. A lot of that is a lot of hype, I have to say. People like to sort of market different things because they want to, sell it as something being, better. What I've tried to do here is sort of focus on, I guess, what we know about the approaches when they've been compared head to head. Okay, so with the posterior approach, it's definitely less technically challenging. From a surgeon's point of view, I can, make the cut smaller or as big as I want it to be. It's definitely reproducible because it's that less technically challenging. But we do have, if you look at the joint replacement registry, we do have a higher chance of revision for dislocation because most dislocations tend to come out the back. And if you're going through the back, you're sort of violating some of the tissues at the back of the joint. So there is a higher chance of revision for dislocation and a higher chance of revision for infection. There's also a tiny risk of injury to the sciatic nerve, which is that main trunk of nerve that runs very close to the back of the hip, but that's very rare. That's like less than 1%. Whereas with anterior, because like I said, it's sort of muscle sparing, you're going through between the muscle bellies, you're not really detaching muscles. It can potentially be done with smaller incisions. Now, people like to sort of market this, and I put lots of question marks here because, it's said to have less blood loss, and, people can take less precautions in that first few weeks after the surgery because of that lower chance of dislocation. There probably is a faster recovery. If you look at the studies that have been done comparing them, there's a faster recovery, but it's not all it's cracked up to be. It's probably a faster recovery by about a week. It's not much longer than that if you look at the well-designed studies. But on the other hand, you do have a higher chance of nerve injury, and it's not like a big nerve. It's not an important nerve, but these are more sensory nerves that cross the front of the hip. So that's actually quite common. It's about 30% of the time that you're going to get some numbness over the front of the hip. A lot of people don't mind that. You just get sort of like this sort of woody feeling on the front of the hip. It's not something that necessarily affects your function, but it can be quite irritating. It's certainly more technically challenging to approach the hip from the front. And if you look at the consequences of that, there is a higher rate of major revision. Okay, so even though I said that the posterior approach has a higher chance of revision for dislocation and infection, those revisions tend to be a little bit more minor revisions. When I say revision, I mean the surgeon has to go back in because something has failed and it means another redo operation. With an anterior approach, because it's more technically challenging, the types of revisions that are done are more major in terms of I have to swap out, a component, and it's usually the femoral component or the thigh bone component that needs to be revised. Now, that fortunately remains very rare. It's about 0.5%, so 1 in 200 extra people, if you like, over a 7-year period. So it's still really rare, but it's definitely higher. And if you look at all the studies that have been done, that's actually quite a common theme. And then the other thing is it probably requires a little bit more resources in theatre. So you need to have a radiographer there. A lot of people use x-rays to screen the hip while we're doing the surgery. So that involves a little bit of extra use of resources and expense. Let's move on to the next question. Different materials used. Again, a very, very common question. So let's talk about that in terms of the two different types of joint replacement. I'm just going to cover knees and hips here. So in knee replacement, they're generally pretty similar materials in terms of there being an implant that's fixed to the thigh bone and the shin bone. And those are usually made of a metal alloy, usually made of cobalt, chrome, or sometimes titanium. And in between the metal bits, there's a plastic, and that plastic is made of polyethylene. Now, some of the newer bearing surfaces are using sort of these new things like cross-linked polyethylene for knees or vitamin E infused. I wouldn't get too distracted by that because, again, that's very early technology. And I think we don't really have good data long-term about whether that's going to be of benefit. So in terms of bearing surfaces for knees, we do have very much a known quantity. I think whatever you get in terms of a well-designed, a good functioning prosthesis that has good results and long-term use in the registry, that's I guess the main questions you need to ask your surgeon. Hip replacements, on the other hand, are slightly different because, again, you can have implants that are then fixed to, the ball part or the thigh bone part, which is this bit down the bottom, or the shell, which is fixed to the socket, okay? So they're usually made of a metal alloy as well. Regardless of what you have there, they all have pretty similar outcomes in terms of the types of the metal alloy implants. But what does somehow, that does affect your outcomes potentially is that bearing surface. So you can imagine that all of the pressure and movement that happens at this ball and socket joint is actually happening at this bearing surface. So in this case here in this diagram, it indicates a plastic liner or a polyethylene liner. But we do have a variety of different bearing surfaces that can be used, either metal, ceramic, or plastic, and combinations of those bearing surfaces. And those bearing surfaces are definitely associated with outcome. And I just want to share this with you. And this is quite a complicated diagram, sorry, but this is literally cut and pasted by the from the joint replacement registry report. Now, down the bottom here, you have basically the length of time after your hip replacement. And then on the left side, you've got a percentage of revision. So as time goes on, more and more of these hip replacements are being revised essentially. And each of these colored lines represents a different type of bearing surface. And what you can see here clearly is that there's a big difference with the black one here being metal on metal. So the things that you do want to avoid are things like metal on metal or non-cross-linked polyethylene, because they definitely have a higher rate of revision, okay? But fortunately, they're not commonly used at all. And this is the power of having a joint replacement registry, is it tells us about these things, and then we can avoid the bad bearing surfaces. So clearly there's some things that we've avoided, and now your surgeon won't offer you these things that have a clear difference. But if you go down to the sort of these other colors down here, like ceramic on ceramic, or the pink one being metal on cross-linked polyethylene, XLPE, or the blue one being ceramic on XLPE, there's only very minor differences between these bearing surfaces. And in fact, if you look at the registry results, it's probably ceramic. Now, obviously, each surgeon will have their own choice and rationale. The differences are very minor, but if you look at the registry results, the ceramic on the cross-linked polyethylene is probably doing marginally better than the other types of bearing surfaces. Okay, so how long does a hip replacement last, since we're on that topic? Again, this is another graph from the Joint Replacement Registry report. This one is for hip replacement. And again, we're looking across time here on the lower axis, and on the y-axis, or on the left, you've got the number of revisions that are being done over time. And you can see that over time, it's a slow increase in the number that need to be redone for one reason or another. And at about 20 years, it's about 8%, which is really a good news story, because 92% of these hips are still, I guess, working well enough for them to not be revised. Now, it doesn't mean that 92% of patients have no problems at all. Remember, we're just talking about revision surgery here. So this is like, you know, a failure big enough in order for the surgeon to need a reason to go back in and do another surgery. So there could be other problems occurring for those 92%, but 92%, it's generally a good result for patients in terms of how you know, how much survival or how much you'll get out of your hip replacement. And it's very, very similar when you look at total knee replacements. Again, if you look over time, we've got over 20 years of results. About 7.7% need a revision if you have a knee replacement. It's important to note that this includes everyone, okay? So this is all ages, all patients, all, you know, potential medical conditions and comorbidities. Now, there are some people that will need, you know, that will have a higher revision rate as time goes on. For example, younger, more active patients, which sort of makes sense intuitively, because they're going to be more active and they're going to potentially use that joint replacement a little bit more than, I guess, a less active older person would. Or a heavier person, for example, would have a higher rate of revision. So if you're obese, that tends to have a higher rate of revision over time. But again, you know, this just gives you an overview about how successful joint replacement is in terms of revision rates. Let's now talk about a different question, partial versus total knee replacement. So Ilana briefly covered this. So this is a diagram that shows you what that actually means. A total joint replacement or total knee replacement means that all parts of the knee are essentially replaced. So you can see you've got, you know, all the compartments here are replaced with a prosthetic, whereas with a partial joint replacement with a knee, it means that only one of those compartments is replaced. And it means that you don't have to do very much with the rest of the knee, which remains intact, as well as the ligaments, which also tend to remain intact. Now, the good thing about having a partial knee replacement is it's, I guess, less invasive. It just makes sense. I'm doing less surgery here. I'm only replacing one part of the knee, and you tend to have a quicker recovery. People tend to feel that they have a more naturally feeling knee replacement, and they have better function after a partial knee replacement. But they certainly, on the other hand, they certainly don't last as long. And that's usually because the rest of the knee, the disease process that's already occurred in that one part of the knee, then goes on and affects the rest of the knee. And then you start getting arthritis in the other parts of the knee, and they don't last as long. So it's about, 25 to 30% revision rate at 20 years when you compare that to the 7 or 8% that I just talked about for a total knee replacement. All right, let's talk about a different question now. So this is about doing a knee replacement, but you've got both knees that are bad, and you're considering whether you should have one knee replacement first and then going on and doing the next one later, or just biting the bullet and having both sides done at the same time, or what's called a simultaneous bilateral joint replacement. Okay, so let's talk about, again, a brief overview of this. Bilateral surgery, if you do both at the same time, you will have a quicker overall recovery, because recovery at the end of the day just needs time. And if you are doing both at the same time, then you're recovering both of your knees at the same time. And also the other positive here, and I've listed this in green, is that you have less impediment from a joint that hasn't been addressed, and it's, can be quite painful from arthritis that already exists there. And now you're having to rely on that joint a little bit extra. And that might slow your recovery down if you have surgery on the one side. But certainly bilateral surgery is a longer surgery. It's more complicated surgery. It's definitely, I guess, a heavier burden on you physiologically. And that means a higher rate of blood loss, and there's definitely a higher need for blood transfusion, but I'm not sure whether it actually translates to a higher overall risk. Now, if you think about risk for having a bilateral knee replacement, you have to compare it to having one side done unilaterally and then having the other one done at a later stage. So you have to sort of add the overall risk of having both of these done at different stages. The evidence for that is not quite there. I think they probably have similar risks overall, okay? Apart from this need for blood transfusion, because you're doing it in one hit, you're losing a little bit of more blood loss in one setting. So there's definitely a higher risk of you having a blood transfusion. But in terms of higher risk of, I guess, other major things like infection or nasty things like heart or lung problems and things like that, it's probably similar based on what we know. So I guess the bottom line here is you should only have the knee replacement if you need it. So if you've got both knees that are really, really bad, okay, then that is an option for you. But if you've got one knee that's bad and the other one's okay and you're able to cope with it and you can manage that without needing surgery, then you should probably not have a bilateral. Only do it if you need it. And certainly you have to be medically fit enough to have, I guess, a longer, more complicated, more major surgery if you do a bilateral knee replacement. So let's talk about another question here, pain management after surgery. This is something that causes a lot of anxiety for patients, and rightfully so, because joint replacement can be very, very painful. Okay, I've not had a joint replacement myself, and there's people here in the room that will, attest to that, I'm sure. It can be very, very painful. I think it's important to expect it to be painful. But I guess there's a middle ground here, because I feel that people who overly stress and anxious about it, and it sort of prevents them from participating in their rehab, that can actually be a downside. So expect it. We can do lots and lots of things to manage the pain at different time points after the surgery. And there's also lots of things that we can do that are not necessarily sort of in inverted commas medical. And these are things like, using hot and cold packs and using compression and, mobilizing and exercising earlier, and distraction therapy and music and all of these things that you can do. But most importantly, I think, is for you to prepare mentally to deal with all of this. Okay. And then in terms of the sort of the more medical things that we can do, that sort of depends on what stage you are at the surgery. So around the time of the surgery, or when you do have the surgery, you're given a whole range of anesthetics, okay? And that can be usually a combination of a general anesthetic, a regional anesthetic, and that can be like a spinal anesthetic or a nerve block, as well as a sort of a regional infiltrate, where we infiltrate anesthetic around the wound to sort of block all of the smaller nerves. Often anesthetic catheters are used on the ward, and then on the ward you're using very strong medications that sort of target the pain from different perspectives. So you'll notice that you're on different types of medication, and all of them are, for pain, but they're sort of targeting your pain from different pathways. And then when you go home, it's sort of the same thing. You're using these multimodal types of pain medications, certainly Panadol, usually an anti-inflammatory, and then an opioid medication is commonly used. But I always aim to cease the opioids early on, because we do know that, prolonged use of opioids is not good for you. It sort of, delays your recovery. It prevents you from doing the rehab and can cause complications in and of itself. And they can be quite dangerous with prolonged use. So we try and stop those in the first couple of weeks after the surgery. In terms of recovery, as Ilana mentioned, each person is different, okay? So I can't give you a straight answer here. Each person is quite different. But if you look at the average, usually it's very light activity in that first 6 weeks, and the rehab programs usually run their course in that 6 weeks. Most of your recovery happens within about 6 months. But if you're looking at full recovery, and if you plot people's sort of pain and function over time, it actually does take about a year to fully get over a joint replacement. Okay, so it does take a while to fully get over it, but usually most of that recovery is in that first 6 months. Now, in terms of driving, a very specific question, very common, and again, wanted to address this, but surprisingly, there's no rules and regulations. It's not like there's a law out there that says, okay, you cannot drive for like a month or 6 weeks or whatever after you have a joint replacement. There are professional guidelines that just sort of suggest what we do. And certainly having those opioid medications that sort of like make you sleepy and zonk you out, you don't want to be on any of those. That's probably illegal to be on those if you want to drive, because you're technically under the influence of a drug. So you definitely have to stop the opioid medication. And you also technically need to have enough mobility to perform a safe stop. And that can be quite different amongst different people, depends on the individual. Obviously depends on the side, if you have your left or right side done, because that's the side that you're operating the pedal. But usually it's about 2 to 4 weeks. And I always tell people to sort of do a practice run, go to a quiet street, or even in your driveway, you can take the car and to see how you go. And if you're feeling safe and confident, then sure, you by all means, you can go ahead and drive, as long as you're off those opioids. I think that's it for me.
Fantastic. Thank you so much, Sam. Lots of really helpful, useful information in there for everybody. So really good to hear from your perspective. I'd now like to welcome Jen and Robert. We're very fortunate to have you both here with us today. You obviously both bring lived experience of having joint replacement. Perhaps I'll start with Jen. Would you like to introduce yourself and also tell us what type of joint replacement you had and when you had it?
Hi, everybody. I'm Jen. I am a 66-year-old who had her first total knee replacement at 56, and then my second one at 61. I had two very, very different experiences with my replacements. The first one, I was terribly naive. I didn't ask any questions, and I had to actually leave the rural town I live in to go and have the replacement done. So I was 3 hours away from home. I was discharged on day 3 for a 3-hour drive home on the back seat of the car with my leg out, and it was a nightmare. I also was on opioids for pain relief, which didn't go well with me at all. So I didn't have it with my second one because I had such a bad, not reaction, but a bad experience with the opioids. So my second replacement, I just had Panadol Osteo. I think they gave me anti-inflammatories while I was in hospital, but I didn't go home on them. But I did have to have, I keep wanting to say warfarin, but the injection you give yourself in the belly so you don't get blood clots. I'm just forgetting the other part of I think anyway, that was really that, and the Panadol was all I came home on. And it was probably a breeze, my recovery with the second one. I probably textbook. I did everything I should have when I should have. But the first one I didn't. The joint, I think I've got two different joints because I actually had two different surgeons, so they're just a slightly different joint, but obviously doing the same thing and still both totals. So what else did you want me to say, Ilana? Sorry.
That's perfect to start with. And where are you at now with your functional sort of recovery, Jen? And is there anything that you're not able to do at this point because of
No, look, there's really, no, that's a lie. I really can't do step classes anymore. They're just way too bouncy for me these days. But I can do short sprints and that sort of stuff at the gym, and I tend to not do pump anymore either, because once again it puts a lot of pressure on my knees, and I do want to try and make them last forever. When the surgeon that did my second knee, when I asked him how long was it going to last, he said it's going to outlast you, so stop asking that question. So I feel quite happy about that, but I still do try and look after myself a little bit. Something that I do struggle with is I can't do group yoga. Oh, well, I can, but I choose not to do group yoga classes anymore because I can't transition as quickly as everybody else in the class, even using aids, because I feel quite numb in my knee area. I mean, I can kneel and all that sort of stuff, but it just takes me much longer to do it. So I choose not to do that. But I found that chair yoga gives me the same benefits. I can do Pilates, but not doing it so much these days because it's got a little bit cost prohibitive. Yeah, so that's it. So I think functionally, I'm just so much better than what I was before I had it done. So, yeah.
Fantastic. Thanks, Jen. It's great to hear how active you are. And Robert, I'll hand over to you. Do you want to tell us about what joint you've had replaced and when you had this done?
Good day, everybody. My name is Robert. I had a left hip replacement surgery last October. I had a posterior incision. I remember my orthopaedic surgeon basically said there wasn't that much difference between posterior or anterior, because I did a lot of research. I mean, there's a lot of information there on the internet, and but I was quite, after having a couple of consultations with the orthopaedic surgeon, I was very confident with the decision making, felt really at ease, and had no regrets in making that particular decision. I first got diagnosed with osteoarthritis about 6 or 7 years ago, and I think mentally and physically the pain and mobility weren't at a point where I thought, I needed to do invasive surgery. But so it was a long journey before I actually got to the level where I had to do hip replacement. But yeah, it took 6 or 7 years. But I wouldn't sort of, I don't have any regrets in terms of taking that long, because I think you have to be mentally confident with the decision that you're making. And when I reached a point when my back went out last year, that was the alarm bell, that signal that I needed to do something. And all the scans and all the experts that I saw, everyone pointed to the same sort of area, being the hip replacement. One thing I initially, when I had the pain, I had pain in the knee, and it was only by chance that I saw another GP that thought it might have been a hip. He wasn't sure. He said, get an X-ray. So getting the right diagnosis, because what had happened was that it was like referred pain in the knee. So I think that was one of the lessons I learned about, making sure that you get that, is it the knee or the hip, because they're both connected. So yeah, just by chance it happened to identify that it was actually the hip that was the problem, not the knee. So there's a lesson learned in my experience.
I think that's very important information too, Robert. Jen, what do you wish you would have known before the joint replacement, and what do you think it's important for people to ask their surgeon beforehand?
Okay, so there was a couple of things that I wish I had have known is one was that my blood sugars were way out of control before I had my first one done, and in actual fact, the morning of the surgery they said you're going to have to start on insulin, otherwise we're not going to do you. So I wish I had have known about that and had have been able to maybe do something along the lines of trying to assist with that a little bit earlier than I knew. The second one was I wish I had have asked a little bit more about the pain relief and, you know, what were the benefits of whichever way you went. And the third thing I think I would have probably asked for in hindsight was maybe doing a little bit of in-house rehab before I actually made that 3-hour drive back home in the car, because I actually think that didn't help my recovery particularly well, doing that so quickly. So I think they're probably the three things. With the second one, I actually had I had a much better experience because, number one, I did everything I was told. And I asked all the questions and I was totally prepared about how I was going to go well through that rehab period. So I did just have day, you know, go and visited the rehab at the hospital when I was discharged. But I did everything that I should have. The other thing was that the first replacement was actually done during winter and the second one was done in spring, and there was so much difference in the temperature, and I found that my leg or knee in the winter surgery felt cold all the time. It felt stiff all the time, whereas in the spring the weather was much better and I wasn't getting as stiff overnight because I was warmer overnight and all of that sort of thing. So so that's probably something for people to think about too. But also look, I think my biggest tip is just do what you're told. So, like, you know, if they tell you they want you pedaling forwards on the exercise bike, do it, whether it hurts or not. Just do what they're telling you to do, and it does. It really does make your recovery go quicker. So, yeah.
Thanks, Jen. That's when you were talking then about the seasons, that actually made me remember that in terms of your rehab, and once you go home from hospital and building up your walking in winter when it's wet and cold, people are often reluctant to be walking outside. So we've had to have conversations about how you can build up your walking indoors. For example, you might be able to get to a shopping centre during a quiet time of the day when you can literally walk up and down and practice your walking there. So that made me think of that. Sam, from your perspective, is there anything else that's really critical you think patients should know before they have joint replacement, or you would want them to ask their surgeon before?
Look, I think sometimes I get the impression that people, you know, dive into it a little bit, as Jen mentioned, a little bit sort of unprepared. They sort of like just, they don't fully know what to expect, but they're in such pain from the arthritis that they just want it to stop, right? And then they don't realize that having the surgery is a really big deal. It's a big deal. It's a big surgery. It's painful. There's lots of swelling and bruising, and you know, there's a lot of work that you've got to do to get over that. Now, I'm not trying to scare anyone off actually doing it, because joint replacement works really, really well. And we know that it's probably, you know, one of the most effective things that we can do for arthritis, if not the most effective, right? So, but I guess the most important thing to do is just to, I guess, prep yourself as much as possible, read up about things from trusted sources. Don't be afraid to, ask for second opinions, talk to people about their experience having joint replacement surgery. Be prepared when you go and see the surgeon. Make a list of questions about things that are very important to you and ask your surgeon, their opinion on all of those issues. So I guess preparing is really, really important. And I think my advice to everyone here is, if you're thinking about doing a joint replacement, just have that in mind.
Great. And Sam, maybe another question for you, if I can. We often hear patients saying that, you know, the recovery process after a knee replacement is so different to after a hip replacement. So just interested to hear kind of your thoughts on that as a surgeon, because I know, you know, in my practice, when I was working with patients after joint replacement, for example, the day after the hip replacement, the patients would say, you know, that deep pain, that groin pain that I had for months and months, that's gone. And now all I've got left is the wound pain and pain around the muscles, which is what you'd expect from the surgery, whereas the kind of sensation of pain after a knee replacement can be quite different and persistent. So how do you see that kind of difference in recovery after knee versus hip?
There is a difference, Ilana. Hip replacement is generally a more successful surgery in terms of, I guess, looking at markers like how happy people are with their surgery once it's all done and dusted. Okay, say a year later, you ask people, were you happy with this? Would you do it again? There's definitely a higher rate of satisfaction if you have a hip replacement versus having a knee replacement. It is harder to do a knee replacement than it is to do a hip replacement. And that anecdote that you just gave, Ilana, is quite common. You know, people feel that they get better very quickly after a hip replacement. The arthritis pain noticeably goes away much quicker. Whereas with knees, I think the arthritis pain is probably also disappears, but it's just so overcome by how painful and how challenging the surgery is, right? Because the surgery, I guess, for one reason or another, and we're still trying to get our heads around why this is really, for one reason or another, is a little bit slower to recover from. There's definitely a more persistent, I guess, more sort of a more longer term persistent type pain when it comes to knees rather than hips. People also feel with their knees that, you know, something is in there, like a little bit more commonly. So it feels like a more foreign object. It feels like, you know, you feel like you have a prosthesis in, whereas with a hip replacement, people generally forget that it's there. It just feels that, you know, this is like more like a normal hip should feel. So there's definitely a difference, Ilana. I would say though, overwhelmingly though, people are generally happy. Okay, so I'm saying even with a knee, you know, probably about 80 to 90% of people are generally quite happy with having a knee done, and they'll repeat it. Okay, whereas with a hip, it's more like 95%. So there's definitely a difference.
Thanks, Sam. I think that's really good for everybody to understand. Robert, I think we might just ask you one final question before we open it up more broadly to questions, but I wanted to ask about the expectations that you had going into your hip replacement for sort of your level of pain improvement and function afterwards, and how well you think those expectations have been met now.
Yeah, one of the questions I was eager to actually ask the orthopaedic surgeon was I heard stories about one leg is going to be shorter than the other, and that did really concern me. And that was one of the first questions I asked when I was doing my, the second opinion. And he said on his record, he had no zero where, he said a zero outcome where somebody had a leg shorter than the other. So that was a big relief, because I was actually surprised, because I had some friends, because I used to play walking football, and some of them have had hip replacements. And that was a bit of a startling sort of revelation when they told me that one leg is shorter than the other, and then I had to go and get something done with his shoe just to sort of get the symmetry back and things like that. So that was a big concern for me. But thankfully, the orthopaedic surgeon actually alleviated that concern for me. The other thing has also been important in terms of what aids that you might, if I can make a point about what aids post-surgery, because before I was doing the operation, I thought, I just went. You had to do this, and that. At the end of the day, all I really needed, it was basically an anti-slip mat in the shower, and then just the higher level toilet seat. I didn't have to have a special chair. I had a recliner and things like that. So I didn't have to go out and buy a lot of aids, or, I had the crutches, which I bought, the Canadian type crutches. After 3 weeks, I didn't need them. I actually sort of gave them to the Green Slopes Hospital. I said, I don't need them. You can have them, and that's somebody else's need them or whatever. So Yeah, look, I didn't experience any pain at all. I mean, apart from maybe, you know, because you had a lot of swelling on the leg and that sort of thing, and you had the compression socks. Getting the compression socks on and off was a bit of an issue when you had to have a shower. But look, generally the pain was like Sam said. Look, from a hip point of view, the only time I experienced pain was when I was actually sort of getting out of bed or getting into bed, making sure that I was elevating the leg simultaneous with the other leg so as to avoid. That's the only time I experienced a little bit of pain. But generally, it's you know, it's been quite a very positive recovery. It's been 6 months, and I'm back doing senior exercise group. I'm doing my Tai Chi. I'm playing table tennis the last month or so, and I'm keen to get back into walking football. But that's a bit more challenging. But, you know, I'm sort of doing a lot of exercises, probably more, maybe 4 or 5 sessions a week, and I'm really enjoying that part of it. And still got a lot of energy for 5 grandkids as well. So it keeps me on my toes. And doing a lot of voluntary work as well is important as well. But just quickly, even talking to a peer mentor in the Arthritis Foundation to speak to someone who's been through it was very beneficial. And that's why I've also joined to be a peer mentor with the Arthritis Foundation, because it was a very positive experience for me. So I thought, you know, I think I've had 3 interviews as well. You don't obviously provide clinical advice, but I think, you know, you're just a sounding board in terms of your journey through hip replacement.
Thank you. That's all really helpful for us, Robert. Thank you, Jen, Robert, for sharing your experiences, and thanks, Sam, as well. Jess, I know we're conscious of time, but maybe we can just take a few questions from the audience. I've seen the chat box has been popping up.
Yeah, definitely. I think maybe about 1 or 2 questions. So there was actually a really good question. Obviously, today we focused a lot on sort of hip and knee joint replacements. And Ilana, you sort of popped up and sort of noted a little bit about shoulder, but there's obviously, you know, it's not as common and not a lot of data. Well, someone did comment that, you know, it was really difficult to find much information on shoulder replacement to sort of inform them going into their surgery. I'm not sure if, you know, that's something you can comment, or, you know, if there's any particular good sources of information regarding shoulder information for patients.
Sam, do you want to kick off with
that? Yeah. There is less information about shoulder replacements because they're just, I guess, a newer technology and they're less commonly done. So, so you're right, there is lesser information. If you try and search for stuff, you'll probably find much less out there. But there are things that you can look at. And again, I'd always encourage people to look at sort of more trusted resources. And I think, the American Academy of Orthopaedic Surgeons to be a really good resource, and they've got fantastic bits of information that is made for patients. It's not all for doctors and, you know, medical professionals. So that's a place that I think that I'd always refer people to have, and they've got really good information sheets about shoulder arthritis and shoulder replacement if you wanted to look that up. So that's ortho info at you know, at the American Academy of Orthopaedic Surgeons website. But yeah, there is lesser information, but if you look there will be some stuff out there that'll help you make a more informed decision.
Yeah, thank you.
And those sorry, I was just going to add to that. I mean, the types of implants, the prostheses they're using for shoulder replacement are changing and developing over time as well. So more of that evidence will come out with time. I was just also going to add that shoulder replacement is another specialty area. So Sam, correct me if I'm wrong, but hip and knee replacement surgeons will tend to focus on the lower limb, the hips and knees, and specialty shoulder surgeons will do that. So if you are being referred to a surgeon for, you know, considering shoulder replacement, then your GP will tend to refer you to someone who specialises in upper limb shoulder replacement. Yeah.
Thank you. And maybe just one more question, and it might be something, I'm not sure, Jen and Robert, you might have some tips. There was a question around accessing rehab, you know, from home and after you've left hospital, particularly for people that live alone as well. And I guess to add to that, I'm not sure if you do have any tips for, you know, in those initial stages when you do sort of go back home, anything that you did, you know, prepare for in the, you know, before you had your surgery, accounting for when you come home and to make things easier.
I think people living on their own really need someone else there with them. I mean, Robert, you'd probably agree with that it's important to have someone around at least probably for the first week or so till you.
Yeah.
So that's why maybe doing in-house rehab would be preferable if you live alone. I mean, I certainly have a friend who lives on her own who had a knee replacement last week and she's in rehab until the weekend. So I think that's something that's important for people to consider if they live alone. Robert?
Yeah, I live alone, but I had my 3 children and I had my grandkids. I mean, you know, it was I had a lot of help in that sort of thing, especially when removing the compression socks. You know, I had my granddaughter helping me out and things like that. So it was a real sort of family affair and things like that, in getting that sort of support and that sort of thing. But yeah, look, I think I went to Greenslopes private hospital, and they gave me a rehab program because, you know, I had the physio. And I diligently followed the program that they gave to me, and then I think within a week or 2 of coming home, I went and saw the physio on site. You know, my son drove me over there, and he gave me all these bands and things like that. So because I've always been fairly athletic all my life, it was something that I embraced, you know, quite naturally, and you know, with all the bands and things like that. And I progressed quite well, just going from one thing to another. The only problem I was probably experiencing in the early days was the squatting. You know, just being because you're not supposed to go below 90 degrees and things like that. But you know, today I don't have any problems squatting at all. But I still don't go too low. I keep within a reasonable range and things like that. But yeah, generally you just follow the program that you're given from the hospital, the physio there. You do that for a couple of weeks, and then the orthopaedic surgeon, as part of his team, had a physio, you know, because he was able to provide feedback to the physio when I had to go, to the orthopaedic surgeon when I had to go and see him. So, you know, it was a real team effort in terms of the orthopaedic surgeon, the staff, the physio, and me as the patient. So it was, I felt really supported.
Yep.
And I didn't have any problems following the program. And
Yep.
I think sort of being reasonably fit helped my recovery even to become quicker, I think. I mean, I played soccer for 35 years, tennis for 20 years. And so, like I said, I've been athletic all my life, and I wasn't going to let hip replacement surgery sort of stop me in my tracks. It did a little bit, but, you know, I was able to resume fairly quickly in my recovery.
Yeah, wonderful. Well, thank you so much. That's probably all we have time for today. We're a little bit over now, but thank you so much, Ilana and Sam, Jen and Robert, for, you know, sharing your professional and your personal experiences and expertise with us, and taking the time out to join us today and have a chat with everyone. Really appreciate it.
Pleasure. Thank
Pleasure.
you. Thanks for organising.
Wonderful. Thanks
Bye,
everyone
guys.
for joining us, and see you next time. Bye.
Bye.